In the next part of the course, we are going to be using a patient model in order to demonstrate some of the different findings that we might find in someone with symptomatic joint hypermobility. We will be doing things like the Beighton score. We will be looking at the skin. We will be looking at joint range of motion in other joints that are not included in the Beighton score. We will be doing an abdominal exam and a heart and lung exam, and also looking at the rib cage and the sternum to look for chest wall abnormalities. And we will be using this information to help derive a diagnosis and establish a treatment plan. So we've talked about the Beighton score and how it is a very commonly used test for generalized joint hypermobility. It's not a perfect test by any means, but it is a very useful test. And we have Callie with us here, fortunately, to demonstrate some of those maneuvers. So Callie, are you okay if we go through the Beighton score on you? Okay, awesome. So the first maneuver on the Beighton score is testing to see if a person can touch their thumb to their forearm. Are you able to do that? Yep, like that. Okay, so not only can she do it, her entire thumb and the base of the thumb is making contact with her forearm. And that is a little different than if somebody's just the tip of the thumb touches the forearm. Okay, and then can you show us the other side? So she has extreme hypermobility there of her wrist and of her thumb that she's able to do that maneuver. And then for the fifth finger maneuver, what I usually like to have people do is actually put their hand on their leg, turn it like that, perfect, and then take that hand and pull that fifth finger up. That is extreme hypermobility of extension of the fifth finger. And then we'll have you do the other side. You don't need to go quite that far. Okay, that's great. That's great. So clearly, when we talked earlier about the being able to go back greater than 90 degrees, there's no question that Callie goes back more than 90 degrees. Here, so we can measure your elbow hyperextension. That's the next 2 points on the Beighton score. So if you could put this arm, we're going to put it out at your side. And then what I want you to do is you're going to put your palm facing the ceiling, and then I want you to hyperextend your elbow. Okay, and then we measure that one with a goniometer. Okay, now you can relax. We measure that with a goniometer to make sure that we have our angles as accurate as possible. And again, it has to be more than 10 degrees in order for it to count, and Callie's definitely is. Okay, now let's do the other elbow. And that's about 18 degrees on that side. So clearly more than 10 degrees on both sides. The next thing we're going to do is we're going to look at knee hyperextension. And I am going to lift this foot up in the air. Yep, so we can make it passive, and you can relax a second. And that way I can get this ready to measure. Get this lined up. Okay, now we're going to lift that leg up. Oop. I need one more hand here. Okay, great. And now you can relax. Okay, so you can see she definitely has hyperextension in that knee. And then this one, I don't think we're going to measure. I think we're just going to demonstrate. So you can see she clearly has considerable hyperextension in this knee. The knee is actually going backward. The angle is going backward. Okay, you can go ahead and relax. Great. That is 1 point for this thumb, 1 point for that thumb, 1 point for this finger, 1 point for that fifth finger, a point for each elbow, and a point for each knee. So far, we are at 8 out of a possible of 9 points. And then the last maneuver, we have to have you standing up. Can you put your palms flat on the floor without bending your knees? Okay, great. Okay, and then you can come back up. So that's the 9th point. And then you can sit back down. So Callie gets 9 out of 9 points on the Beighton score. And then another thing that I often ask people is if they have any party tricks. I don't normally want people to do these over and over again because that's not good for our bodies. But for the purposes of teaching, if there's any, don't do them yet. Okay. If there's any party tricks that you happen to do, I often, when I'm seeing a patient, I'll have them do those party tricks, and I'll either take a video or I'll have their family member take a video. So that way we've documented it. Do you have any party tricks like that that you do?
You already did it a little bit, but okay. I can do it farther.
Does that hurt by any chance? That does not hurt. Okay.
But this one I don't feel at all.
Okay. So that is a fascinating point, that it doesn't hurt. So the reason why I have people, show me these things and we talk about it is because it's good. I really appreciate you doing this for the purpose of the course. You don't want to do that on any kind of a repetitive basis, because I'm so glad it doesn't hurt. We don't want it to hurt in the future. So thank you so much for demonstrating that, though. Any other party tricks?
I don't think nothing like that. I don't think so.
Okay.
Yeah.
Okay. All right. Very good. I want to just take a feel of like your kneecap for a second. You can just completely relax your leg for a second. Yeah, you can. I can feel that her patella, that's the kneecap, is has a lot of motion to it, and we can really see that on both sides. Have you had much issues with your kneecaps? Have you dislocated your kneecaps before? Yeah.
I think this one more, but both of them. The first time it happened was more of an actual dislocation, and now they more just slide in and out.
Okay.
And I don't feel it so much, but then later on when I'm doing other things like just walking or going up the stairs, then it is painful.
Sure. So the first time that it happened, was it more of a traumatic thing?
Well, I was on stage, so I was having a lot of adrenaline.
It happened when you were on stage?
And I did not feel it. And then when I came off, I couldn't really walk. And I had like, when it swells and it gets like a water, remember? That happened. And I could not walk. And then I went to physio and they said, well, you dislocated it.
Oh my goodness. Right. Once something is dislocated multiple times, then it can slide out and slide back in without a whole lot of effort. So that's one thing that I think a lot of people don't realize. Oftentimes the first time is a bigger thing, like you said, but now things are looser, so that happens more readily. And you can even see that the head of her humerus is really far forward. Like if you picture where the head of her humerus is in the socket, she clearly has a lot of range of motion of her shoulders also. Do you do any of the kind of weird internal rotation things that people sometimes do? Yeah. That's not normal to be able to do that.
Or like this.
Okay. And do you have any of some of the like related things like scoliosis? A little bit. Okay. No problem. Okay. And then if we can have you, I'm going to have you spin around again. You can see that her scapula is we call it winging if they don't have as much scapular control, and it kind of is sticking out more than quote unquote normal. And one of the techniques that you've had physical therapy, right? Have they taught you putting the angle of your scapula into this back pocket technique? No? That can be a helpful cue. I've been in and out of physical therapy since I was your age. So that's a lot of years, of course. So that's a cue that's been really helpful for me in stabilizing my shoulders. I mean, there's lots of exercises and things to do, but thinking of that, the edge of this scapula, the bottom, the inferior medial edge of putting that in this pocket can be helpful to kind of get the scapula to be more up against the rib cage. So, okay, great. So we were just talking about the range of motion in your feet and your ankles. So can you show us your feet and how much you can plantar flex and dorsiflex? Yeah, so that's a lot more dorsiflexion than you would expect, and plantar flexion. Can you show me the other foot? Okay. Very nice feet for dance. What about inversion, where your ankles go? Yep, in like that. Okay, can you do the other one too? So yeah, you can see that is definitely much more range than normal. And eversion, yep, definitely much more than you would normally expect to see. And you were also doing something with your toes. Do you need to stand up in order to do that, or?
Well, I can just do it like this, but I kind of got most of the cracks.
Okay.
I do that.
Okay.
Yeah.
Yep. And those are the kind of things we don't normally want to do, but for the purposes of this, like that's what we see when we see hypermobility. So if you could turn and face that way, yep, so we can see your knee hyperextension. That's very helpful. So again, we can measure it again here. Let's see. Okay, and now you can relax. Okay, so that's on that side about 11 degrees. Let me have you do the other side, but just wait a second until I'm ready. Because generally speaking, I want people to stand with soft knees, not hyperextended knees, but for the purposes of taking a measurement. Okay, so Whenever you're ready, is that as much hyperextension as that knee will go? Okay. Okay. Yeah. So that's about the same. So your elbows are definitely more hypermobile than your knees, but that's a super common thing. I feel like elbows are more commonly really hypermobile. Can you face that wall for me? Perfect. Okay. And now we're going to look at your heels. So if we look at her feet, she has these bumps on the outside and the inside of both feet. And so maybe we'll have you rotate 90 degrees so you're facing me. Perfect. And then hopefully you can see those bumps over here. And then you can rotate another 90 degrees. Yep, that's perfect like that. This foot is more pronounced than the other foot. And when you check for pyogenic papules, you do need to have the person standing because otherwise it's not a reliable test. And then you want to rotate another 90 degrees for us if you would. Yep, so maybe you're facing that way. Perfect. Okay, great. Now face me again. And we also want to demonstrate the pronation that you have in your feet. So you have the flexible flat feet that we often see. Can you stand on one foot maybe so we can see the inside of, I'm sorry, the other way? Oh, sorry. And I know you probably don't need the hand for balance because you're a dancer, but you can see that her foot here is very flat. The arch is gone. Okay, now you can put the other foot down. And then let's have you rotate another 90 degrees. Same thing with that foot. Okay, great. And then if you can face the camera, and then just stand in kind of try to stand in a normal, natural position. But you can see that the line of gravity doesn't go right through the middle of her foot, that this is kind of collapsed inward on both sides, like that. So seeing that pronation is another thing that makes us think, oh, maybe this person has a condition of symptomatic joint hypermobility because they have this laxity. Yeah, exactly. Can you rotate and face that wall so we can see what that looks like from the back? And again, just try to stand normally, but we can see that the line of gravity that should come down and hit in the middle of her foot instead is going to come down and hit inside of her foot. So if we can work on improving that pronation, that can often help with alignment all the way up the chain of the body. So thank you, that's great. So Callie, can you also show me how what your range of motion is like of your wrist? Yeah, okay, so that's definitely not normal. Okay, and then what about the other one? Okay, yep. And then what about your all of the fingers? Yep, okay, without the wrist. Okay, thank you. Okay, so that's extreme extension. A person does not need to be able to go that far or be able to do that many maneuvers in order for it to be considered that the joint is hypermobile. You happen to have extreme joint hypermobility in some of the joints that you've showed us. In your hands, quite a bit more so, I would say, than your knees so far. Your knees are hypermobile, but you really like that fifth finger. That's really, that's really out there. And then another thing that I often do is I'll just feel a person's wrist and just kind of feel like how lax that is. And yeah, you definitely have more than the normal amount of laxity in your wrist. And let's feel the other one. And that you just kind of have to get used to over time. And we also just want to find out, like, are there any joints on your body that to you subjectively feel loose, or all of them, or?
I mean, the wrists do feel pretty loose. Mm-hmm. This knee a little bit. Mm-hmm. I like sometimes I'll like with it.
Oh, don't do that anymore.
Yeah. And obviously just this finger, right? Like I feel nothing if I push it all the way back.
And that is a great point. I'm so glad that you said that. That's one of the things I think that's particularly challenging for dancers or other people that might be doing stretching to a more to a more extreme point. They'll keep going because they don't feel it.
Yeah.
And it's like, that doesn't mean that, exactly. That doesn't mean that that's a good idea, but you're trying to go for a sensation, right? So
I would say my back also used to be extremely loose, but I think over time it's tightened.
Mm-hmm. So. You were telling me about one of the maneuvers that you used to do. Maybe you could describe that to us.
Well, it's called a chest stand, but you basically lay on your stomach and your legs come up over and you're like on your chin. And I used to stretch my legs out. So then my butt would be flat on my head and my legs would be flat on the ground. But I don't do it anymore.
And so what you're describing is your head is here and your back is extended like this, and basically your bottom is sitting on top of your head. Okay. You used to do that, but you don't do it anymore.
Yes.
Can you share with us why you don't do that anymore?
I actually physically cannot do it anymore because I used to do things like that so much that my back has tightened so much and I just can't move like that anymore. Like it does not move that way anymore.
Sure. And you're only 16.
Yeah.
Right? Okay. Yeah. That's a good thing for people to be aware of, to be mindful when you're younger.
Too much.
Yeah. Do you wish that you had done some things differently when you were younger?
I think every once in a while, like, well, because of dance, I think it was like a cool party trick, and I think it, just people liked it. Maybe do it once in a while, but I would do it every single day.
You used to do it every single day?
Because we would do it in class. Like it's actually a move that they teach you in class. So let's say I was in a contortion class, they would get you to do that. And so I thought it was normal. I didn't think it was going to harm me. And then I stopped doing it because my back was getting extreme pain. And now I can't do it. I can probably, if I stretch, I can get my feet flat, but I can't straighten them. But I have extreme back pain now. Like, just my back hurts every single day from doing nothing.
Your back hurts every day. You're 16. Your back hurts every day, and you're not even doing that kind of maneuver anymore. When did your back first start hurting?
Oh, God. I mean, I think it's always had a bit of pain, just like my knees have always had pain, whatever. But I would say it got very bad when I was probably 11, 12.
Wow.
Yeah.
So
that's when I started cooling it on that because it was too painful.
Sure.
Yeah.
Wow. That's pretty young to be having back pain like that. Yeah.
It's a lot worse
now. And could you tell at that age that you could do those kinds of maneuvers much more easily than other people, or more easily, I should say?
For sure. I didn't fully understand why. Like, I knew I had connective tissue and a bunch of other issues, but I don't know. I just was like, I can do it. Like,
sure.
Years. And then other teachers, like, obviously they don't know all these medical things. So they just see a kid who's very flexible and they like it and they want you to be their star. They want you to win, you know what I mean?
Right. Yeah. And you want to win, right?
Yeah.
So,
I wouldn't say it's their fault, but sometimes I would say some people abuse it a little bit. Because I don't think anyone should really be bending that much every day.
Yeah, the back was not meant to have that much extension. That's really extreme. So, okay. So right now, I just suddenly noticed too that Callie's skin was kind of mottled a bit. So she's both in her arms and in her legs. It's like a lacy type pattern. Do you have dysautonomia or your autonomic nervous system has difficulty sometimes? I think your mom had mentioned something about your heart rate being kind of all over the place at times and things like that. Okay. So that's something that we see not infrequently. Are you cold right now too? Because that
not particularly.
Okay.
But sometimes when I'm cold, it gets I call it I think it's like scales. Like I think I look like a reptile. But I find when I'm like cold, it'll like become purple. Like right now it's more red a little bit.
Right.
But even down in my legs, you can see it's a little more purple. Sometimes it usually gets worse than this.
Sure. Okay. And speaking of skin, you're young, so I would expect you to have nice skin, but you have really soft skin.
Yeah.
And that's one thing that's one of the criteria is really, really soft, like doughy skin. In fact, if I feel your hands, like
it's my hands especially.
Yeah, your hands are really, really soft.
Yeah.
I wish people could feel this because your hands feel almost like a baby's hands, like super, super soft. I don't know if people can see. And also you have that kind of translucent skin where you can see more veins than normal. And that's also something that we see with connective tissue issues. And I just noticed right now, just do this with your fingers a second. Yeah, so you can see the extension in through there. And then let's take a look at the other side of your arm. Yeah, we can see like some veins in here. We can see that modeling pattern. Oh yeah, now it's getting more pronounced. Yeah, we can really see it on that side. So, and then oftentimes we'll see what's called atrophic scars, where the scar actually kind of heals like below the layer of the skin. But I think with the condition that you have, actually, that's not something that we normally see. So you probably won't be able to demonstrate that for us, but that's okay. And otherwise, I think we can maybe move on to the next section of the exam. So a few other skin findings that we would look for is to see if someone has unexpected stretch marks. So it's really common when people go through puberty or if they've gained weight, it's very common for people to have stretch marks. But sometimes people that have symptomatic joint hypermobility, especially if they have a connective tissue disorder, they will have stretch marks even though they never gained weight or they're prepubertal or they got them before puberty. I don't think you have any really, but that is one thing that we always want to look for on this skin exam. Yeah. Another thing that we like to look for is how stretchy is the skin. Yeah. So, and sometimes I have people do this on themselves. So if you can pull your skin on your forearm there, oh yeah, that's pretty stretchy. That's more than 1.5 centimeters. So that's what we're looking for. And then can you do the other arm? Yep. Okay. Yep. Okay. That's quite stretchy, especially for your age. Yep. You want to show me the other hand? That's great. Yeah, and checking multiple sites is actually really helpful. And then can you also show on the side of your neck? Okay, and then what about the other side? Okay, great, thank you. Have you ever seen the pictures online where they're really stretching out the skin on the neck and it's like crazy, crazy out there? It doesn't have to be like that. In fact, if a person has skin that's that stretchy, then we start thinking of some of the different subtypes of EDS, but like for the hypermobile subtype, we're looking for what's called mild skin hyperextensibility. So we're looking for that like 1.5 centimeter on the forearm kind of a thing. Okay. So let's look at your neck range of motion. So I want you to start with tipping your head to the side. So tipping, well, you go either direction. That's fine. Yep, that's okay. Okay, and then we'll have you tip the other direction. Okay, good. And then we'll have you come back up to normal, and then rotate your head towards me. Yep. So that's pretty extreme. Your tilting, I feel like, is pretty normal. Okay. And then now rotate your head to the other side. Perfect. Okay. Then come back to normal. Then I want you to turn 90 degrees so that we can see a little bit more precisely. Can you flex your chin down to your chest? Okay, good. So she's able to touch your chest completely. And then I'm going to move your hair out of the way. And then you can straighten back up. And then can you extend your head? Yes. So, okay. Okay, you can relax. I'm always afraid when I do that I'm going to have to help somebody get their head back up on top of their spine. Okay, so that's really interesting because when you tilted your head,
it felt really tight, actually.
Oh, really? Yeah. Interesting. So maybe that,
like extremely, I couldn't really go. I don't know.
I haven't really palpated your neck yet, but I wonder if some of those muscles in there are really tight.
I do get extremely tight in here and up going into my head.
So. And does it come out like this or?
Yeah, it's like right in here and out into here.
Yep.
And then also up like into like the base of my head.
Yep. Yeah. So you know what we call that cape pain. It's in the shape of a cape. Yeah. So it starts up here and then it goes out onto the shoulders. That is extremely common. And I think that's due to a variety of things. One reason is because the head is extremely heavy. Think about the head as like a golf ball sitting on top of a tee. And it's really a lot of energy for people who have joint hypermobility to maintain good posture, and especially to have that head sitting on top of the cervical spine. Yeah. And so nowadays in society with texting and everything, like more and more of us, we call it text neck, or we do this. But if you have joint hypermobility, it's even more problematic because it's harder for your muscles to be able to compensate for that, and because you have so much laxity, then you can go farther, and the head gets heavier the farther it is away from the like optimal place on top of the spine. So yeah, thank you for demonstrating that. That especially the extension was very, very significant on the high end. So okay, very good. Okay, so you were going to show us, I think, a couple of things with your shoulders. So you were doing a maneuver where you were basically. So that's.
Yeah, and I can feel it like pop.
Yeah. So that's a lot of range there. Are you able to let's see. I just want to kind of feel your shoulder here a second. Let's see. Let's turn your body. No, the other way. Sorry. That's okay. And so if you just relax and I pull on your shoulder, I wanted to see if, yeah, you do have a sulcus sign. So we can see kind of like a divot in here. Okay. And otherwise, let's see. I think we can go on to the next section then. Okay. So you were just showing me another thing that you could do with your shoulders. Can you show me one more time that thing that you just did? Oh, that's really interesting. So you must have touched your neck up here.
Is it really red?
Yes. So yeah, so turn your body a little bit to the side. And I don't know if you can appreciate these marks on her neck. So that to me looks like what's called dermatographism. And dermatographism is something that we see with people who have hyperactive mast cells. And when they scratch themselves or you scratch them, they will get these raised marks that will last for a while afterwards. So that looks like dermatographism to me. Okay. So now we're going to feel your neck. And I'm feeling for a number of different things when I'm palpating your neck, okay? So I'm feeling, first of all, for lymph nodes, for any enlarged lymph nodes, because a lot of people who have symptomatic joint hypermobility, they have fatigue. And it's extremely important that we don't over-attribute everything to a person's symptomatic joint hypermobility, because a person can have another condition, like, God forbid, a lymphoma or something, or some other problem that would, like a persistent infection or something that would show up in their lymph nodes. There's a saying, people are entitled to as many diseases as they damn well please. Have you ever heard that saying before? Yeah. So a colleague of mine said that, I'm not sure who, but it's very true. That's one mistake that I see people make sometimes, is they attribute everything to hypermobility, and it's not necessarily the case. So lymph nodes feel like little bumps under the skin, and they're part of the lymphatic system, or part of the lymphatic drainage that we get from different parts of the body that basically go into the center of the body, and they get enlarged when you have an infection. So it's normal to have enlarged lymph nodes, like in your neck, when you have an infection. So it'll feel like more like a marble or something like that. If you have an enlarged lymph node, but you had a recent infection, or, the doctor's already checked it out and they say it's okay, that's one thing. But if it ever feels like hard and difficult to move, that's important. That's usually a worrisome sign for any lump or bump in the body, if it's hard and difficult to move. Or another important criteria is if it's something new and it's a enlarged lymph node and you haven't been sick, then that's something that you want to bring to the attention of your doctor, especially if you have fatigue, because that is something that can, be potentially a cause of fatigue. So I'm just feeling around your neck and just feeling, like I said, in that anterior cervical chain. And then I'm feeling around the posterior cervical chain. And I don't feel any enlarged lymph nodes, but I can feel back along your upper trapezius and at the base of your neck, and even around your ears, and just make sure that none of those feel enlarged. Okay, so that's the first thing that I do in the neck, okay? Now, the second thing that I'm doing is I'm also just kind of feeling for muscle tone, and it feels like you have good posture, but your head is slightly forward. That's like a common thing for all of us, and it feels like these muscles called your anterior scalene are a little bit on the tight side, but that's really, really common because they're having to do more work to stabilize the neck. So feeling more tightness in that anterior scalene muscle is quite common. And then the next thing we're going to do is listen to your heart and lungs.
Okay.
So another important part of the exam is to do a heart and lung exam. So again, we want to make sure that if a person has joint hypermobility, that they don't have something else going on, or that they don't have an explanation for their fatigue or for their orthostatic intolerance, meaning that they have difficulty standing up, being able to stand up for any extended period of time. And there could be different problems with the heart or with the lungs that could attribute that. So I'm just going to take a listen to your heart and lungs here. And I'm just listening for the actual beats, and then to make sure there's no murmurs. And you can just breathe completely normally for now. Sounds good. So what I'm listening for is, first of all, regularity. So there's two parts of the heartbeat or heart sounds. There's the S1 and the S2. So basically what your heartbeat sounds like is dum, 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 dum. And yours was nice and regular. It wasn't like dum, dum, da, da, dum, dum, there were no like long pauses. It wasn't like super fast. It wasn't super slow. That all sounded really good. Okay. Now I'm going to listen to your lungs. I'm going to listen in the front first. So take a deep breath for me. And then I normally listen on the back in several different places. So up high, both sides, kind of more in the middle on both sides, and then down low to make sure that the air is going all the way down into the bottom of the lungs. And I know we talked before about atelectasis, which is collapse of the small airways of the lungs. And that's something that we see with a lot of different conditions, including if people are in bed a lot. So if somebody is really having a lot of problems with their joint hypermobility and they're spending a lot of time laying down, then you can definitely get atelectasis. So oftentimes when a person has symptomatic joint hypermobility, they are describing symptoms that are going on in multiple different parts of their body. And so sometimes we would miss, unless if we do a thorough physical exam, we might miss another contributing cause of that person's symptoms. So we want to make sure that they don't have a valvular problem or something like that that either could help explain their symptoms and or could be part of the criteria for hypermobile EDS. We do know that mitral valve prolapse is one of the criteria for hypermobile EDS, but we need actual measurements from an echocardiogram, not just listening on an exam, but that is one of the criteria for the hypermobile type of EDS. Okay. So, but yeah, we want to make sure that we have evaluated the cardiopulmonary system, because if there was a problem in the heart or the lungs, that could contribute to problems elsewhere in the body, because that's what circulates the oxygen, brings the oxygen in, and that's a crucial part of the machinery of the body, if you will. So another really important part of the exam is looking at a person's facial structures, because sometimes that can give us clues to certain genetic conditions. So we want to be looking for things like we talked earlier about vascular EDS and how there's certain facial features for vascular EDS. So sometimes that person will have like a really thin nose. They might have deep set eyes. They sometimes have what we call lobeless ears, really thin lips. You don't really have like features of that I see, but you do have like a little bit more of a broad forehead, which is something that we definitely look for. And also your eyes are like a little bit farther apart, which, you know, again, we're just looking for clues because we're trying to solve a mystery when somebody is experiencing these things. So these are the kind of things that we're looking for. Okay, so another thing that we want to be looking at is the person's rib cage and chest wall, and make sure that they don't have a chest wall deformity like we often see with Marfan syndrome. And Callie does not have either a pectus excavatum or carnatum, and we will have images of that in the show notes for the course. But that is something that you want to check for while the person is sitting and or laying down. And another thing that I often like to do is palpate their ribs. And you were telling me earlier, why don't you tell me again what you were telling me about your ribs?
Well, sometimes, I don't know the exact definition of what it is, but more in the back part of my ribs, not really the front, I would call it like a subluxar dislocation. It's not, I don't know if that's actually what it is. I'm sure it's not. But it would feel like one rib or something would go out of place and it would go inwards, and I would have difficulties breathing because it would feel like it's actually hitting something in there. And then it also makes it difficult to move because it's like it's actually hitting something. And it actually happens a lot. Like if I were to crack my back, I can feel something in my ribs or back is now out of place, and I can actually feel it. Usually, like, there's more extreme things that make it go out of place, but sometimes even just cracking it can make it feel like that.
Interesting. And is that something that still happens or something that used to happen? Still happens. Okay. And have you ever found anything that helps with that?
Well, I would go to the chiropractor, not for cracking, but she would have like a little, I don't know what it's called, but a little like...
Maybe an actuator?
I don't know. It was like a silver thing and she'd like push it.
Yeah, that's an actuator.
And it would like just realign and push things back into...
And that would help?
And that would help so much.
Okay.
But the actual cracking of the chiropractor, that's what makes it hurt more.
Sure.
So just getting it realigned, I can't put it back on my own.
Sure.
So that was helpful.
Okay. Okay, great. So I appreciate you sharing that, because the ribs, I think a lot of people don't realize that the ribs actually form a joint in the front with the sternum, which is the breastbone, this bone right here. So your ribs form a joint in the front with the sternum, and then in the back, they actually articulate or form joints with their vertebral bodies back here, and they will actually connect with both the one that's above and the one that's below that rib. So you describe that so articulately, and what you are feeling really fits scientifically with what we know, that even ribs can be hypermobile and can sublux, which is a partial dislocation, or they can completely dislocate. So it's really interesting the way that you are describing that. And I actually have patients who have what's called slipping rib syndrome, and their ribs move around so much that they run into a lot of problems. Like you said, it becomes difficult to breathe and difficult to move because you don't realize how much your rib cage kind of stabilizes everything. Your diaphragm is connected at the bottom of your rib cage. That's essential for your core muscles. And of course, the ribs are essential for breathing. So when people run into problems with that, it can really be challenging. I've had patients that have had ribs sutured to other ribs or sewn to other ribs, sewn together, or have had ribs removed for that. But that's where you knowing about this at an earlier stage and figuring out what works for you and what doesn't work for you and keeping your body strong is really essential, because keeping as much muscle on your body as you possibly can and making sure that you're using good muscle patterns, good neuromuscular patterns, etc., is going to really help you in the long run. So another part of the body that we like to assess the range of motion is the lumbar spine. So if you want to turn around a minute, perfect. So the cervical spine is up here. Then we have the thoracic spine, which is where the ribs connect. Then we have the lumbar spine, and then into the sacrum, which is the solid bone that's at the bottom. And then the coccyx is the tailbone. So in order to assess for range of motion of the lumbar spine, first thing I'm going to do is actually stay this way so that we can see your back. That actually works out perfectly. Put your hands at your sides if you would, and then lean towards me, kind of run your, perfect. Okay, whoa, wow, that is definitely much more than, okay, come back up. That is much more than most people can do. Okay, now let's have you go the other direction. Okay, great, then come back up. Now for the next part, I'm gonna have you turn and face this direction. Oh, okay, well, perfect, come back. And then turn and rotate the other direction. Okay, and I was gonna have you, let's have you rotate your feet 90 degrees away from me. I'm sorry, turn your whole body 90 degrees. With your feet. Oh. You're so bendy. You're like, which part do you want to go which direction? Perfect. So for this, what I often do is I will hold a person's hips so that when they rotate side to side, I'm just looking at the spine and not, they're not actually rotating like in the knee and that kind of thing. So now I'm going to hold your hips and I'm going to have you do what you just did over again. Okay, great. And then you can come back the other direction. Okay, great. Thank you. Okay, now I want you to roll down and touch your hands to the floor. Okay, great. And then come back up. And usually when a person does that, I'm also doing kind of a gross test, feeling their spine, looking for any scoliosis. And then I want you to do extensions. So, well, if you feel comfortable doing it, do you feel comfortable doing that? Are you sure? And you don't need to go too far. Just go to where you feel completely comfortable. Okay, that's great. That's great. Okay. And that's extension of the spine. And as you said earlier, you used to actually sit your bottom on your head. That's how much extension you had in your spine. Okay, very good. So looking at the range of motion of the lumbar spine can be very helpful for determining if a person has more than expected range of motion in that part of their body. So I also like to do an abdominal exam. It's really, really common for people with symptomatic joint hypermobility to have gastrointestinal problems. And I don't know if you've ever experienced any of those or not, but that is something that a lot of people experience. So we're going to do that next. Okay. I usually tell people if they need to bend their knees that they can. Are you comfortable like this, or would you like to bend your knees? You're okay like that? Okay, great. So the first thing that I do is observation. So I'm just going to be looking at your belly to see if I see anything abnormal. If I can, sometimes in thin people like you, I can actually see almost like the peristalsis, like, food moving through depending on when they ate or whatever. And so that's the first thing I do is observation. The next thing that I'm going to do is I'm going to listen. So I'm listening to see if I hear bowel sounds, which would be a normal finding. It would be abnormal to not hear bowel sounds. So I'm going to listen to see if I hear bowel sounds. And I listened in all 4 quadrants. And if you've ever had your head on someone's lap or something after they've eaten, you know what bowel sounds sound like. It's just like that gurgling sound. Yeah. So have you heard that before?
Yeah.
You know what I'm talking about? Okay. And that's literally how it sounds through a stethoscope. Yeah. It's just a little louder. Yeah. It picks up on more subtle things. Okay. So then the next thing I do is I palpate their abdomen. So again, we don't want to miss any big things like a mass in the belly or anything like that. Sometimes we can even feel the aorta, the big blood vessel in the belly. Sometimes we can feel that. And so I'm going to go ahead and palpate your belly. I apologize if my hands are cold. Okay. Okay. So I'm just going to kind of feel your belly a little bit. And I usually start out with light pressure so the person kind of can trust me and knows that I'm not going to just go cramming onto their belly. And then around here is your bladder. So if someone's having a lot of problems with their bladder, they might be really sensitive in that part of the body, or having pelvic pain. Pelvic pain is a very common problem. Pain kind of in this part of the body. Okay, so none of that hurts? Okay, so I kind of made a circle. Now I'm going to go back around again, and I'm going to feel a little bit, I'm going to press a little bit harder. Does any of that hurt? No? Okay. Okay, good. I don't feel any masses or anything like that. I'm going to feel again in the middle just to see if I can, yeah, I can feel your abdominal aorta. And I don't think that that's a problem because of your size. Okay. And it doesn't feel like it's pounding out of your belly, but I can feel it. Okay. And the aorta is the big blood vessel that carries the blood from the left side of the heart out to the rest of the body. So it's that big blood vessel that's going to come up this way, and it's going to carry blood to your arms and to your belly and everything. So the abdominal aorta is a very big blood vessel because it has to carry the oxygenated blood into both legs. Okay. So it's not uncommon that we can feel that, but that is also a blood vessel that often we have to measure and monitor over time if we're concerned about a vascular problem, like vascular EDS or something like that. So then we measure that size of it and monitor that over time. One of the criteria for the hypermobile type of EDS is dental crowding. And I'm not a dentist. I usually ask the person, did you have issues when you were small? Were you told that your mouth was too small for your teeth and that kind of thing? And did you have that? Okay. Okay. So you had to have a retainer at a young age in order to make space for your teeth and that kind of thing? Okay. Okay. And then the other component of that is we're looking to see if a person has a high arched palate. So usually I have people open their mouth and kind of tip their head up a little bit. Oh yeah, you definitely have a high arched palate. Okay. So if you can look at the camera and maybe we can zoom in a little bit. Yeah. So you can see her mouth is small, and she also does definitely have are you able to tip back just a little bit more? There we go. Okay. So you can see that that's very narrow. It's hard if a person hasn't looked in a lot of mouths, it might be a little hard to know what narrow means because obviously I'm not putting a number on that. But yours is definitely narrow. And as an anesthesiologist, I've looked at a lot of airways over my lifetime. Yours is definitely narrow. The other thing that we often see with that is dental crowding. So people often are told they had too many teeth or their mouth was too small for their teeth. Did that happen to you?
Yeah, they said my mouth was too small to fit everything.
Okay.
Yeah.
So did they give you a retainer or something like that?
Yeah, I had a retainer, yeah.
Okay. So another thing that we want to look for in people with symptomatic joint hypermobility, and it's part of the criteria for both Marfan syndrome and hypermobile EDS, is something called arachnodactyly. And yes, that does come from the same root as spider, and it means long fingers and toes. And so first we want to do what's called the Walker test, which is where you wrap your fingers around your wrist and you see if you can overlap. So you can touch like me. Oh, wait, actually, it has to be this finger. It has to be the 5th finger. Yep. And I know you said you don't have long fingers and toes, so you probably are not going to be able to do these things, and that's okay. But the Walker test, you can wrap your hand around and not just touch, but like overlap by that last knuckle. So we do that on both sides. And then there's also the Sternberg test, where you put your thumb inside your hand and you close your hand. And if you can stick your thumb out the other side, then that's a positive finding for that. So that's how we do the test for arachnodactyly, long fingers and toes. And that is an important thing to evaluate when you're evaluating somebody for symptomatic joint hypermobility.